डॉक्टर वहीदुज़्ज़मा साहब को वो किसी तारीफ और तारुफ के मोहताज नहीं, क्योंकि ये हमारे मुल्क के मायनाज वायरोलॉजिस्ट हैं और इन्होंने काफ़ी ज़्यादा जो है स्टूडेंट्स अब तक प्रोड्यूस किए हैं, बेतहाशा उनके रिसर्चेज़ हैं। सो वहीदुज़्ज़मा साहब बहुत बहुत शुक्रिया आप आए हमारे पैथोलॉजी सेशन में। एंड टुडे सेशन विल बी मॉडरेटेड बाय डॉक्टर हाजरा फारूक. So I request Dr. Hajra to please proceed and moderate the session.
With disclosure and disclaimer, I'm an employee of Illumina, as you can see. I will start with reminding everyone was our mission. You probably heard it yesterday from my colleagues, but our main mission at Illumina is to unlock the power of the genome to improve the human health in all clinical sectors. Then for today's talk, I'm going to start with some quick introduction on PAP, followed by oncology genomic overview. The third section will be introduction of CGP or comprehensive genomic profiling for the patient, and then followed by some clinical studies of the TGP. And the final one will be on key takeaways for today's talk. So starting by the targeted therapy. So as you can see in this slide, the precision medicine changed drastically for the last couple of years. So following the latest NGS technologies and the latest technologies around the globe with some regulatory landmarks from the FDA-approved treatments and drugs, we've seen more and more FDA-approved treatments and drugs being discovered, being approved, and so on. So the therapeutic landmarks changed drastically. So we have more than 49 drugs already with the genomic aberration already approved. Few of them, they are quite agnostics, regardless of a solid tumor, what type it is. And then the rest, they are targeted therapies with a specific biomarker for a specific type of cancer. And again, here I'm just showing how the clinical management changed and the paradigm changed in management of the non-small cell lung cancer. So in the past, it was considered as a one single disease. But nowadays, we're looking at the molecular pathology of the disease. So we're trying to identify the exact genomic adaptation for this, trying to have the proper treatment and the genomically matched therapy for those patients. Again, because of this precision medicine era, more and more the clinical trial design is more adequate to be up to the standard. So with the proper genomic testings, we can identify different types of clinical trials, either the umbrella trial or the basket trial. As you're probably aware, for the umbrella trial, we always try to have one cancer, for example, in the case the lung cancer, and then we screen for different biomarkers, and those different biomarkers made with multiple therapies for the same type of cancers. For the basket trials, it's a different approach, which is what we start with the multiple cancer types, but to identify a single biomarker in those different cancer types and try to have a single therapy for the specific biomarker from the different pan-cancer approach. So enabling this precision medicine, you need to have the proper understanding of the biology of cancer. And once, as you can see in this slide, I'm showing the evolution of molecular testing when it comes to oncology patients. So what you see the trends is more and more they're moving towards comprehensive testing. So the majority of labs, they are familiar with the IMC, the FISH, the PTR, Sanger sequencing, and so on. They're moving towards the panels, or what we call it now, the CGP, which is the comprehensive genomic profiling. So, and then what we see in the future as well, we have more to focus on whole exome or whole genome, and we're going to combine it with some multi-omics, have a holistic up for all the cancer cells in that patients to offer them the proper therapy or proper treatments for their cases. And the reason for this as well, because as you can see in this study, it shows a huge spectrum of genomic adaptation across different tumor types. There's multiple genes that are involved in different of cancers. That's why it's very important to understand the genomic adaptation in order to provide the personalized targeted therapies for those patients. In addition, as well, in each type of cancers, there's like a huge hallmark. So very big genomic drivers, like for example, the growth suppressors, the immune destruction genes and biomarkers. That's why it's very important to understand the hallmark of those cancers to try to match it with the proper targeted therapy for those patients to give the best outcome for their cases. In here as well is showing in nice publications showing how the targeted therapies have dramatically improved the outcome. So on the left side, we're comparing the patients following by Jimmy in black color, and the blue one where they had a placebo for that treatment. And you can see the overall survivors drastically it's much better increased versus the placebo effect. At the same time, on the right side, you can see the maximum change in the tumor size following appropriate therapy, following a 30 fusion plots for those solid tumor lists. So again, in this slide, showing the example of how the therapies will be beneficial for the patients after the genomically matched Again, in this slide, showing the outcome and how it's improved following the genomically matched versus the unmatched therapy across the different tumor types. You can see in blue, matched therapy the overall response rate, what we call it ORS, it's more slightly higher than 30%, versus the non-matched therapy, which is less than 5% overall response rate. As well, on the right side, it shows as well the matched therapy in blue versus the non-matched therapy in black. So here as well, with more focusing on how, if you properly identify the genomic landscape for the cancer, and then you provide the genomically matched therapy for them, it will have a advantage for their patients' response and overall survival rate. And the molecular tumor board. So this is why it's quite important when we come to the precision medicine. So it's very important to put different experts in the same room and discuss challenging cases for oncology patients. So it's quite important to get the pathologists to be available as well and discuss the molecular profiling for those patients, the imaging, the clinical history, and then this multidisciplinary molecular tumor boards and discuss case by cases and try to have a kind of a specialized treatment plan for each and specific patients, not keep it as a standardized for all the oncology cases. Moving on from the oncology testing overview, so it's a nice summary in here where we see currently the diagnosing when we do the cancer patient. So many cancer patients, they still diagnosed at the late or an advanced stages. And with a quite high 5 years mortality rate. But we envision in the future this paradigm should change. So we're gonna be part with our states throughout the journey of that. So we trying to have some early detection, so more patients will be diagnosed at an early stage of the disease, and offer for them as well a comprehensive assessment. So we're gonna study the tumor biology for those cases. And during the matched targeted therapies, we gonna try to have a sensitive monitoring for them. Especially we're gonna check the lower tumor burden, the recurrence for this, and try to monitor personalized treatment. And this will enable us as well to have some longer therapies. So more targeted therapies, improving long-term survival. What we see, what we envision in the future, that at early stage of most of the cancers, it will decrease the mortality rate. So this is the comparison between the current paradigm and the future when it comes to patients. The reason for this shifting actually is there's changes in biomarker profiling as well. So you can see more and more growing list of biomarkers from the DNA and from the RNA perspective. They've been added or recommended by international societies, as well from the PAP cancer or the genomic signature approach. And it's advantage that the you as pathologists something is the limited sample availability of cases. There was a big need to develop a single and a neutral multiplex assay that could that could leverage on that approach and change it to the biomarkers for oncology testing. So in here, there's like a couple of studies showing the additive single gene testing approach. It leads how to different patients and biomarkers. For example, the non-small cell lung cancers, you need different biomarkers to be tested. That means different methods, different techniques, and different slides required for that testing, as well as higher turnaround for it. And into this, you'll be missing on the new biomarkers like prime MPs as well as URA, which is quite valuable to be assessed for each and every patient. So we envision in our approach to have, instead of going for a different of states or methodologies and different type of slides required for that and different report analysis and so on, we have the vision of comprehensive genomic profiling using one assay, one workflow, very fewer slides required for the analysis, and a general one unified report that contains all the variants and based on the international recommended guidelines, as well as having embedded the clinical trials and the peer-reviewed literature to be available in this final report to be shared with the patient. So in here as well, I'm just showing some ASCO and ESMO guidelines when it comes to solid tumors. So you can see the list of biomarkers, and the actual biomarkers is increasing every year almost, and so on. So that's why there's a big need for those type of patients a kind of a comprehensive approach for different biomarkers testing. In addition of this as well, from the DNA and the RNA perspective, as I mentioned, for the important to check MBs or the tumor mutational burden, MSI as well as the CDS. In addition as well, this is coming from as the ESMO recommendations, large panels are increasingly being recommended for the multiple solid tumor types. You can see CGP or large panels be recommended for the case of the lung adenocarcinomas, prostates, ovarian, and UP. And it can be recommended for cervical, salivary, thyroid, vulvar, and neuroendocrine. And that's why as well you can see more and more recommendation from the international society of the importance of a large or a comprehensive panel for a different biomarkers to be involved in a pan cancer approach for those cancers. More on the comprehensive genomic profiling and what it enables in precision medicine. So because of the DNA and the RNA variants, they are not only one of the advantage of offering PGP for the patients as well. You'll be capturing the NDs, the RSI, and impact biomarkers as mentioned earlier. And so this comprehensive profiling, the results will have the ability to have the maximum actionable variants for those cases, as well as it will lead to molecular matching therapies like immuno-oncology and the clinical trial enrollments in different pieces, and eventually, hopefully, it will increase the clinical outcome for the patient. As well, from the sample approach, it could be a tissue or liquid biopsy sampling, so there's no difference between both type of sampling, as well as a consolidation of single single assay with all these biomarkers being identified for those patients. And the advantage of CGP, as mentioned, with the different variant types in single assay, you can detect the base substitution like KRAS, for example, certain deletions like EGFR, copy number alterations, gene arrangements like the intrax, tumor mutational burdens, as well as microsatellite stability. So you can see clearly that the CGP offers a comprehensive approach for all type of variants in a single assay that would be needed for your oncology cases. And here's just showing some list of studies that CGP can identify more clinically relevant variants than any conventional single gene testings or even a small hotspot panel. So you can see that as well if you apply a small hotspot panels, you can miss about 80%, 81% of actionable mutations in patients with suffering, in this case, from refractory cancers, based on a study of the patient cohort. So just a small example, if you do not apply CGP for those patients, you'll be missing a lot on different types of markers that could be relevant for the cases and make significant changes in the management of those patients. More on the utility of CGP. So by providing for your patients a comprehensive providing information and quite accurate diagnosis for their cases, you will be enabling and making patients who are identified as eligible for therapies or immunotherapy. So with therapy, you'll be matching towards the appropriate biomarker treatment for that case, as well as from the immunotherapy perspective, with the proper matching of MSI and TMB, as well as the HRD for that case. And eligibility will be enrolling those patients with the proper clinical trial based on the biomarker identified for their cases. And here we're showing one nice study. Again, we're talking about the non-small cell lung cancer patients. So if you don't apply for them the CGP, you'll be missing about 96% of the cases or the actionable biomarkers. And that's why it's quite important to offer for those patients, as you can see from the cohort, the CGP approach. So a comprehensive approach for the MDs, for example, as well as the clinical trial eligibility for those cases. In addition, here we grouped some nice publications showing that CGP enables a large number of patients to be genomically matched to the appropriate and approved investigational therapies. So from different cohort of different studies and different tumor types from the PAP cancer approach, but not the specific ones. Here as well, showing four nice publications showing the progressive free survival rates and the overall survival rates. As you can see in blue, with treatment going by a genomically matched therapies, and you can see both the OS as well as the PFS it's increasing, which is the non-matched in green genomically guided therapy. Again, it's in the same previous slide saying that the treatments management for those patients with the genomically matched, it improves the overall survivors of cancer patients as well as the progression-free survival rates. And here's some of the clinical benefits of CGP, where it shows in different publications starting a few years back, and some are quite recent, where they compared CGP and versus other testings, like FISH testings and other methods testings. It shows that CGP improves drastically the detection and accuracy of the actual biomarkers. And you can clearly see in the previous slide why is that, because we offer a comprehensive approach for all the biomarkers for those cases. In addition, as well, it shows in the different study list as well. It's mostly from Europe and the US that improves the selection with the CGP for those patients and improves the survivals for those cases. And that was as well showed in a few slides back. The last point is actually if you offer CGP for your patients from treatment perspective, you'll be offering as quick as possible, and you avoid any delays and waste in time, waste in the patient health, as well as the type of tests involved in it, the sampling, and so on. And this is the advantage of offering a comprehensive approach when it comes to oncology patients. As the key takeaways as the last slide from my presentation is, as you can see from the different studies I showed during this presentation, that if you apply a sub-test testing or the traditional testing methods, like single genes or even small panels, you will not be able to detect all the actionable genomic drivers and biomarkers for the tumor cases. And that's why it's important to offer for those patients a comprehensive genomic profiling and try to match those genomic biomarkers with the proper therapeutic options available for those patients. So with this CGP approach and the precision medicine, you'll be enabling them to have access to therapies with the matched biomarkers, as well as the immunotherapy molecular signatures like MSI, and HRDs, as well as you'll be eligible for patients to be admitted for the biomarker certified clinical trials or following biomarker identification for those cases. And that's it. If you're happy to have some feedbacks and download the presentations and more on the material, please feel free to scan this barcode. Thank you for your attendance. Thank you.
Thank you, Dr. Mehroon, for such an insightful talk. Do we have questions from the audience?
Two questions, if you want to ask, so that we can. The speaker is with us online and he has to go. So, please.
Thank you very much. It was a very insightful presentation. Just that you are really covering all the genetics getting wrong in terms of the tumor mutational burden and other things. Do this comprehensive genomic profiling include the epigenetic markers as well, like methylation signatures, microRNA presentations, and things like that?
No, it does not. So that's why what happened in the majority of the labs, they combine the CGP approach with the methylations and the classifiers. So it's all based on the guidelines. So what you've seen that some physicians, they add the epigenetic factor on top of CGP for some specific cases.
Okay. Second is basically, once we understand that epigenetics has to play some kind of like role, are they like to be included in this comprehensive genomic profiling? Because one set all approach would be like kind of beneficial. So do you kind of predict that these CGP markers, CGP profiles would be having these kind of markers being added at some time?
I believe so, yes. And I know we are working on this. If you remember what I showed you in the early slides of the presentation, the evolution of molecular diagnosing for cancer patients, we will not stopping at the CGP level. There's way a bit more from that. So there's more for the future approach, for example, the whole exome sequencing and the whole genome sequencing for oncology cases. And it's as well for somatic as well as liquid. And then on top of this, you'll be adding as well the methylations, the epigenetic approach to be added on top of this. So in terms of oncology testing and even genetic testing in general, we are still in early stages, I would say, to diagnose all cases and offer this exact personalized treatment. So this is one step closer for the next one. But yes, to your point, we personally envision that we're going to add more from the epigenetic perspective and the methylation approach for this holistic kind of testing for those patients.
Fine, thank you very much.
Any other question?
Yeah, there's a question.
One question. One more. Yes, please.
Thank you, Boutros. This was really fascinating. I have a couple of questions, but I'll use your feedback form for that. One question for now is, if you add Pakistan or a developing economy filter to this, how does it look like? How does the next 5-10 years of genomics look like, right? We're a quarter of a billion, we're the 5th largest country, but most of it is out of pocket, most of it is low purchasing power, right? So how do we deliver these fruits to the masses, and how do you guys look at it from an Illumina perspective?
Yeah, that's a good question, and I've heard it from different countries, especially from what we call it emerging markets at Illumina, not only Pakistan, but others as well. So the way that we see this is, of course, it's we and you guys would love to employ this test for all type of patients and all type of cancer approach. So what we see is more and more evidence needs to be generated from the same country. So that's why we try to work with our partner GMS in Pakistan to enable more the evidence generation or the local implementation for this type of studies. And we would love to work with you as the societies of pathology and the oncology in the country to develop some local guidelines. Now, it's very easy to implement, for example, the ASCOs or the ESMO guidelines, but we need to consider as well the country limitation in terms of price sensitivity for the testings, the limitation of patient management, and there's one more factor which is quite important, is the clinical trial availability in the country. So that's why we need to work with the pharma, and we need your support in this to enable more and more clinical trials to be enabled in the country itself, not to being sent out to the US or to Europe and so on. So all of these factors, it takes time. So if you get back to your question, 5 years, yes, I would say in the period of 5 years, we should have this test kind of offered for, I would say, not the majority of the cancer cases, but a nice percentage of the cancer patients, especially at advanced stages, should be benefiting from this, because there's a huge benefit for them from the clinical managements. But again, as I mentioned in the previous questions, we are still in the early stages, and there's way more to cover from the everything. So the first one is the availability of this test in the country, training on the workflow, as well as on the reporting, because for these reports, they're quite comprehensive, and that's why it's quite important to know how to do the counseling for these patients. And the most important factor is enable clinical trials for some of those cases and some of those patients. So we need to engage with the pharma as well to have more and more clinical trials available for those type of patients. So eventually, on the long term, they will benefit from this test, and what's the changes in the management that's coming from it.
Thank you very much, Dr. Bashros. We would have listened to you more, but I think we are running short of time. I'm really thankful for such an enlightening talk and giving us some clue for the future how we can proceed. Thank you.
Thank you so much for the rest of the conference.
Our next speaker is Dr. Michael Abdul. As a business unit manager, Michael brings together his knowledge of Illumina solution, but also the application by a large cross-section of customers across the field of microbiology, infectious disease and agrigenomics, with 20 years experience working across Africa, Middle East and Asia Pacific. Having read at the University of Western Australia in Pathology and Molecular Biology, with subsequent business studies at Royal Melbourne Institute of Technology, Michael has worked in diagnostic laboratories for both human and animal health and completed postdoctoral training in the field of protein engineering. Prior to joining Illumina, Michael supported the adoption of laboratory automation, becoming acutely aware of the importance of laboratory workflows and quality control, from sample handling to next generation sequencing, library preparation. Having gained experience in most molecular assays, from southern plots to polymerase chain reaction to NGS, Michael has developed a clear understanding of the application of molecular technology and the utility of the data generated. The topic of his talk is new genomic workflows for pathogen identification and surveillance of antimicrobial resistance.
Good morning, everyone, and thank you to the organising committee, both for that introduction and the opportunity to present on behalf of Illumina to you today. Now, I'm mindful of the challenges of remote presentations, so like my colleague Boutros, there is a QR code that I present here, and will do so again at the end of my presentation, which will give you an opportunity to access additional information, for us to reconnect if you have any questions that we're unable to address in this short period today, but also to leverage that information in speaking with my colleagues who are able to join you in person in the hall. So with that, I will segue to really thinking about the utility of next generation sequencing. And some of you in the audience may be familiar with NGS. Some may indeed be more familiar with phenotypic antimicrobial susceptibility tests that exist and remain a cornerstone of clinical practice in the area of antimicrobial resistance detection. Now, NGS is not necessarily a replacement for those methodologies, but rather an opportunity to leverage a reflex method for culture-negative samples and thereby complement this phenotypic surveillance. And indeed, this peer-reviewed article out of the British Medical Journal, published a few years ago, really reiterates that value proposition for NGS and the methodologies that you have using NGS. So, for example, whole genome sequencing can be used to infer transmission between humans and animals. thereby tracing the origin. This allows you to achieve far greater reproducibility and resolution, and with that, determine the genetics and loci responsible for the resistance, thereby allowing you to understand pathogen evolution, population dynamics, but also potentially develop new treatments and therapies. And so for the balance of my talk, really what I would like to propose in mentioning and highlighting the methodologies of NGS is the opportunity to shift from reactive response to holistic surveillance. Effectively, this is much more about, or much more greater than the diagnosis of an individual to leveraging that information to the benefit of the community. And so for the remainder of the 20 minutes that I have with you today, there really are only 3 sections to my presentation. The first, really looking at what it means in terms of pathogen identification. The second, to very quickly highlight just a few real-world applications. And then the third is just to crystallize that and call out some of the specific solutions that are readily supplied and supported through Illumina. But of course, I always like to frame this with something of a reality check. And so for that, and this information that I've drawn from the oracle that is Google, calls out effectively trends within the search engine for specific search terms. And I've standardized this with COVID-19, something that we're all acutely familiar with in terms of pathogen surveillance, and something that clearly reflects the search, the public interest, and indeed the waning interest in pathogen surveillance over the last few years. Now, as long as we have had antibiotics, we have had antimicrobial resistance. And interestingly, on that same time scale, you can actually see that there has been a fairly consistent interest in antimicrobial resistance. But if you immediately overlay that with the interest in recent terms for COVID, you can see that it is effectively zeroed. And so despite this being a much greater emerging problem, a threat that has been identified and called out by many global health authorities, you can see that the general awareness to antimicrobial resistance is low. What's more, if we think and refer to the topic that Boutros presented in terms of oncology, you can see that the general awareness for oncology itself is far greater than pathogen surveillance. But a sobering thought is if you then actually look at all of those health practices relative to something as ubiquitous as YouTube, you can see that the general awareness is much, much lower for things relating to health practice, pathogen surveillance, and the likes. And so, with the promise of NGS, the hope, indeed my hope, is that the utility of the methodology will increase awareness to the broader benefit of the population as opposed to something like YouTube. And so with that, I'll segue then to what it really means to utilize NGS. It is indeed a powerful tool for strengthening infectious disease surveillance. And fundamentally, NGS really can drive the increase in speed for the detection of the outbreak, deepen the molecular understanding of pathogen behavior in the community, and thereby enable development of alternate, the deployment of existing therapeutics. Effectively, NGS really allows us to rapidly sequence genomes of infectious agents at a pace far greater than what we've seen before. And all of us are acutely aware of its utility now, having lived through the last few years of the COVID-19 pandemic. What it ultimately allows us to do in terms of strategies for pathogen surveillance is really implement a One Health approach. NGS-based infectious disease surveillance really allows us to combine and analyze both human health as well as that of reservoirs for pathogens within the animal and plant kingdoms. Particularly crucial moving forward as the environments become far more intertwined through urbanization, far more challenged through climate change. And so in regards to pandemic preparedness and indeed the utility of NGS in this paradigm, there really are three pillars by which we utilize the technology. The first, on the left-hand side of screen, is really around early detection, allowing and utilizing genomic interrogation of pathogens through NGS to address that early detection, and through early detection, really inform epidemiology and the likes. Preemptively in many cases, if one considers wastewater surveillance as opposed to merely analysis of individuals who present to public health authorities. From early detection, we move to outbreak response, and here it leverages a concerted effort of public health officials, clinical laboratories, healthcare professionals to effectively leverage that genomic data obtained by NGS and then track transmission at a local or a national scale, monitor new variants of concern, map disease clusters, and inform public health priorities and interventions. And the hope, should that be implemented, is that blanket lockdowns could be avoided in future epidemic, pandemic responses. And then, of course, post-event, we segue to the third pillar on the right-hand side of screen, which is clinical research. And really, this is about identifying the mechanisms of action, both for the pathogens within the environment, but then also in terms of host response, ensuring that we can manage the severity of the disease within those that are infected, and ideally provide a degree of community immunity through vaccination, the development of new vaccines, development of new antibiotics, and the likes. And some of the applications of NGS that have been utilized really draw upon four key and common methodologies that are in existence, that are routinely practiced globally. Now, these can be quickly summarized as highlighted in the orange box on screen as either shotgun DNA or RNA sequencing. Sometimes you might hear this being referred to as metagenomics or metatranscriptomics, whole genome sequencing of cultured isolates, hybridization or hybrid capture being the third methodology, and then the fourth methodology being amplicon sequencing, which basically leverages aspects of polymerase chain reaction or PCR, as well as NGS in a single assay. Now, fundamentally, what all of these allow for is culture-free methodologies to identify the DNA and RNA sequence within the sample. That alone provides us not only with additional information, but an advancement in terms of turnaround times, but also the opportunity to deal with pathogens that may not readily culture. If I then focus back on those three pillars of early detection, outbreak response, clinical research, and give a few examples against those four methodologies, one can't go past that of an endemic disease, both before and after COVID, in regards to TB. And indeed, the disease burden in Pakistan is one of the highest in the world, specifically in regards to drug-resistant Mycobacterium. Pakistan generally is regarded in the top 5 full countries in regards to the disease burden. So the specific example I call out here is from India, whereby utilizing amplicon sequencing, researchers were actually able to deploy NGS as a rapid detection of drug-resistant mutations. Now, this is not replacing cost-effective detection methodologies, being either a smear, a PCR, a line probe assay, or the likes. But this is specifically to address that portion of the population with whom drug resistance is the major issue. And through this amplicon-based methodology, the researchers were actually able to detect drug resistance at a much faster rate than that of culture-based phenotypic tests, basically reducing the median turnaround from 21 days to 3 days, significantly improving patient outcomes, and with that, detected far more drug-resistant associated loci, and as such, therefore can inform the use of the drugs available and at least suppress the increase in drug resistance and therefore the utility of those drugs that are available now. Coincidentally, this meeting of yours coincides with the Union Conference in Paris. Some of your colleagues might have attended. At that meeting, Illumina highlighted specific methodologies that we have released, in addition to that which this customer developed, that allow for both whole genome sequencing as well as targeted NGS methodologies for TB. And these can be readily deployed both at centralized laboratories and remote labs as well. A further opportunity to deploy NGS is that in a scalable model for NGS-based surveillance for influenza. Again, an endemic that causes much disruption to communities the world over. If one looks to recent World Health Organization disease notices, already the Northern Hemisphere is faced with a significantly severe flu season, with alerts being raised for Europe and North America. Now, NGS, as utilized by this particular customer through hybridization capture, allows them to indeed far better diagnose upper respiratory infection through the use of a panel that now can actually identify both the serotype of the influenza itself, but also comorbidities, co-infections that might actually influence both the treatment and the patient outcome. And this study clearly positions the utility of hybrid capture methodology as a powerful tool for passive infectious disease surveillance. But one can't ignore the crossover between the kingdoms. And indeed, in this example that I present, here we have the screening of antimicrobial resistance within piggeries in Italy. In my backyard in Australia, earlier this year, we had outbreaks of Japanese encephalitis within the majority of the piggeries in the country. And so as part of routine animal surveillance for AMR, whole genome sequencing can be used to indeed manage, control both antimicrobial resistance, but then to also inform the movement of livestock across country and therefore limit any outbreaks, both in terms of their commercial impact, but of course in terms of the health outcomes as well. And so this particular study prompted much greater advocacy for NGS and genomic surveillance within piggeries, but it extends to avian influenza as well as many other pathogens across the animal kingdom. If we segue to outbreak response, and I will resist the urge to focus on COVID-19, for which we're all familiar, but look again at some endemic enteric pathogens such as Salmonella, which in this instance in Johannesburg, the National Institute for Communicable Diseases again leveraged whole genome sequencing of cultured isolates to actually trace a specific outbreak and indeed identify the likelihood of a larger contamination problem and therefore limit the impact to the broader community. Very straightforward, a practice which isn't necessarily unique, but a practice which is greatly informed through the application of next generation sequencing. And so if we then segue to clinical research, and indeed in this instance, I can't go past the example of COVID-19. The reality is the rapid deployment of vaccines, the development of vaccines for new variants has been directly informed through next generation sequencing. And indeed, since its inception in 2010, Moderna has leveraged NGS exclusively, or extensively, I should say, within its pipeline for vaccine development. and it did so very effectively in developing its vaccine for COVID-19 and subsequent iterations as the pathogen itself evolved and developed an increasing number of variants of concern. And so with that, I will call out the final few slides of my presentation, which just hopefully will link some of those 4 methodologies and terms that I've referred to the practicality of implementing NGS in your particular practice and laboratories. Now, Illumina fundamentally is a genomics company. It is one of the oldest, but having said that, only celebrated its 25th birthday this year. In being a genomics company, it produces a number of flexible and scalable platforms, as well as the reagents, so effectively what we refer to as the wetware, and the bioinformatics tool, the software, to allow for infectious disease surveillance, both of novel pathogens, to facilitate insights into clinical research, to facilitate the surveillance and tracking and transmissibility of those pathogens, as well as host genetics and vaccine development. Now, the slide after this will present as something that possibly is quite confusing, because there are indeed a multitude of options depending upon whether your hypothesis is to address and inform a known pathogen, a suspected group of pathogens, or if your hypothesis is in fact free of any specific group and the like. So effectively you approach the experiments in a hypothesis-free manner. Irrespective of which solution, which hypothesis your experiment takes, all NGS methods actually have a standardized workflow. So for those in the audience that haven't perhaps utilized NGS, it can seem rather daunting, but it shouldn't, because all of these workflows fundamentally only have 4 steps. The first being that of the isolation of the genetic material, the second being the preparation of sequencing-ready libraries, the third being the actual sequencing of those libraries, for which the Illumina instruments do the bulk of the heavy lifting, and the fourth really representing the utility of that data through the analysis and interpretation. Now, where that can seem overwhelming is when you look at all the options available. But fundamentally, despite that catalogue of library preparation reagents being rather extensive, they fundamentally can be divided into 3 categories. First, whether or not you are targeting a known pathogen. So in other words, a single genome, which represents those on the right-hand side of that spectrum. Thereafter, if you have a suspect or likely pathogen, maybe you're interrogating multiple pathogens at the same time. And these are reflected in the hybrid capture methodologies down the bottom of the screen. And thereafter, hypothesis-free discovery, where it, by all accounts, is a shot in the dark. And these are those on the top left, those methodologies that allow you to explore all pathogens within any given sample or host. And so with that, I really come back to those 4 methodologies. So broadly, those kits that were mentioned on the previous slide would fall into one of these 4 groups that I mentioned earlier and address each of those hypothesis approaches. What it means, however, is that we have the tools. We also need to support the use of those tools. And so I can't look past the technical support, the training programs that are available. Now, this might be thought of something that only applies when one has an instrument. But I would actually encourage you, if you haven't already, to go to the Illumina resources online. There are a number of education programs, trainings, tools, and the likes that can be accessed free of charge to anyone within your team to provide further insight, greater detail to the methodologies, to the specific science and technology behind next generation sequencing. And indeed, that can inform your choices and your implementation of NGS in your own laboratories. What's more, that reflects our belief and our commitment to global health, whereby it is to move beyond products and really focus on programs that strengthen health systems, that decentralize the necessity for hands-on sequencing skills and technology, and build public health surveillance that really benefits the community at large. And it speaks to some of the comments made following Boutros's talk about increasing access to this technology and the benefit for the broader community, despite the perceived upfront costs and the likes. So with that, I really close with just a single message, perhaps aspirational, but no less important. And really, in this era of genome technology, disease, one hopes, particularly communicable diseases, do not have to be a disaster. And so with that increased knowledge, with that increased information, leveraged appropriately, we can apply it both at a local level, a national level, and a global level to avoid a repeat of the COVID-19 pandemic and its outcomes. As I alluded to, should you wish to circle back for more information, please utilize this QR code on screen. My colleagues who are able to join you in person and thereafter contact me directly after the event. So once again, thank you, and if time allows for any questions, more than happy to answer those.
Thank you, Michael. I'm thankful to you, but I think we are running short of time, and I advise the audience that they can ask you questions online if it is so needed. I'll proceed further. Thank you.
Welcome, and do enjoy your day and the rest of the meeting.
So now we have three papers. The first one is Unraveling SARS-CoV-2 Diversity, Variants of Concern During Fifth Wave of COVID-19 in Karachi. Our presenter is Dr. Hafsa Majid from Dow University of Health Sciences.
Assalamualaikum and good morning everyone. I'm Hafsa and I'm the fellow of Molecular Pathology, and I'm here to present a part of my thesis titled Unraveling SARS-CoV-2 Diversity, Variants of Concern During Fifth Wave of COVID-19 in Karachi. So in this presentation today, I will first walk you through a brief introduction of COVID-19, the objectives of my study, the materials and methods that we used, the results that we got, and the conclusion.
I think we will have question answer in the end because we are running short of time. And without slide, if she can present, please go ahead because we can't waste the time.
Okay, so basically the objective of my study was to identify what the prevalence of the most common variants are during the fifth wave of COVID-19. So as we know that whenever there is a greater wave, it's mostly associated with a prevalence in one of the variants of concerns that we've had, alpha, beta, gamma, delta, and Omicron. So in our study, what we did was we collected SARS-CoV-2 samples that we did throughout 1 year, and we extracted RNA samples. We then ran RT-PCR to identify the positive cases, and we ran those through next generation sequencing to receive the whole genome of those samples. We aligned them with the reference Wuhan strain, and then we identified the mutations on the basis of which we assigned on the basis of which the program Nextclade assigned the variants that we received. So the most prevalent variant notably was Omicron, and we also saw that there were some specific mutations that we got, most notably E484A and D614G were the most common mutations that we identified in our samples. And these mutations are important to note because these are associated with immune evasion and stronger affinity with the host receptor, the ACE2 receptor. And they also are mostly since spike, these mutations are present in the spike protein, and since spike protein is the target for most therapeutic reagents and the most of the vaccines as well, that's why it was important to identify mutations here. So I'm just going to go directly to the results. So we saw that Omicron was the most common variant during the fifth wave. We also identified on the basis of districts where we saw that East District had the highest number of cases. Over here we have done the phylogenetic tree construction of the sequences that we observed, and we saw that while only a few were closely related to the Wuhan strain, most of them had evolved further away from the original Wuhan strain. On the basis of lineages, the most common lineage was the XX-B, but we also identified other lineages in our samples. And out of the clades, the most common one was 22F, but again, there were a few other as well. This is what I was talking about. Among the spike protein, E484A and D614G were the most common mutations, and since these are involved with immune evasion and reduced neutralization, it is important to address these. 3 other deletions were also identified in all of the samples. So to conclude, it was basically that since most of us already know that Omicron was the most prevalent variant in fifth wave, but we were able to identify other mutations that were also important to note. We also saw that East and Central districts were the most affected areas in Karachi. And that we also saw that since we observed diverse clades and lineages in our sample, we see that how the virus evolves over time. And it is important to address these evolutions through public health measures so that the viral transmission doesn't get out of hand and we face another pandemic. That's it. Thank you.
Thank you very much.
Dr. Zumara Yunus from Quaid-e-Azam University will talk on genomic-based characterization of Enterococcus species in emerging pathogen isolated from human gut.
Assalamu alaikum, good morning. So this was part of my PhD thesis, the genomic-based characterization of Enterococcus species and emerging pathogen isolated from the human gut. Basically, I was working on irritable bowel syndrome patients, and during the culturing of the stool samples, we come across that a lot of Enterococcus species were there in the stool sample. So we take it, the Enterococcus species from the stool sample, and I did the whole genome sequencing of the Enterococcus using the Oxford nanocode. So currently I am working in GMS as a quality control head of the molecular technology. So this is a brief introduction. As you all know, Enterococcus, this is an important bacteria of the lactic acid bacteria. Usually we think that Enterococcus is a gram-positive, it doesn't cause any harm. But the researchers, they prove that the Enterococcus is now acting as an opportunistic pathogen because it have evolved different types of antimicrobial resistance gene in it. So the aim of my study was, as we are running short of time, so I am just summarizing. So the aim of my study was to determine the genome of Enterococcus species isolated from the human gut and to analyze the virulence and antibiotic resistance genes in Enterococcus using the whole genome sequence. So I did culturing, biochemical testing, different antibiotics, the manual antibiotics testing. Then I compared the results with using the Oxford nanopore technology MinINE. I did this part in USA just to compare the phenotypic characteristics of Enterococcus. That is, phenotypically it was resistant to different antibiotics. But what were the genes that are involved in that antimicrobial resistance? So using the Oxford nanopore technology, I studied that. So I coming toward the metabolic network that I observed in the Enterococcus species, we saw that different among the 4 different varieties of Enterococcus, their GC contents was varied like 38 to 44%. Also, the base pairs and the number of the genome size is also varied among the different species of Enterococcus. I performed different type of analysis on the genomic data. And I saw that bacteriocin related, 13 genes related to bacteriocins were present in one of the species, Enterococcus calyphyllus, and I named it as QAU15. 8 genes, they form a cluster and they produce colicin B. I also formed that in this one of the species of Enterococcus. 9 genes, they were present in 2 strains of Enterococcus gillarium and they produce bacteriocin. So this was a detailed summarization of the genetic characterization. You can see here that different factors like adhesion, toxin, bacteriocin, resistant to antibiotics and toxic compounds, virulence, inhesion and intracellular resistance. So different type of genes are present in different species of Enterococcus that I have isolated. So this was the genome size and the features. I have compared the 4 different types of Enterococcus that I have isolated with already present reported genome NCBI. So here is the summary. You can see the picture here that most of the genome was related, but we can see here that the genome was fragmented, and most of the Enterococcus, it evolves with the time. It can change its genome with the passage of time. So this was a circular map of Enterococcus species. As I mentioned earlier, that GC content of different species varies. The genome size also varies. Their number of coding subsystems and the coding sequences, also the number of different RNAs present. These all genetic details, they vary from species to species. I have also saw the antibiotic resistant genes that are present in different species of Enterococcus. Mostly vancomycin resistance genes was present in all of the 4 different types of Enterococcus that I have isolated. 2 of the genes were also showed resistance against the ampicillin. I used the CART software to find the presence of antibiotic resistance genes, so I can see the presence of different types of genes reduced. So this is the summary. You can see here the vancomycin resistant genes XY, vancomycin resistant gene RC, VANC-C. These all are present in different types of species. So what I conclude from my study was that different types of mutations was present in Enterococcus, especially in the region, especially the genes that I have worked on was vancomycin C1, VANC-XYC, and VANC-RC. So more studies, of course, needed to study the metabolic pathways of these genes and how these genes transfer from one species to another. So previously, the researchers thought that we can use the Enterococcus as a probiotic, but now the studies are coming. So it cannot be used as a probiotic species without the whole genome sequences. We can, by whole genome sequencing, we can differentiate between the pathogenic and non-pathogenic forms of different Enterococcus that are present. And moreover, the benign technology that I have used, this is very cost effective as well as time consuming and very easy to perform. So, of course, more studies are needed to study the metabolic pathways in the Enterococcus bacteria, that now why this bacteria is now becoming more and more antibiotic resistant. Acknowledgement, my professor, Dr. Amir Ikram, at that time he was heading NIH, so I worked under his supervision. He was my PhD supervisor. Dr. Imran from Khaizazm University, he supervised me. The University of Minnesota, the technology that I have used, MINAI, Professor Dr. Sagar Goyal, he was supporting me. And of course, without the help of FIP and MH, I cannot do this study because they all give me the patients to study this. So Major General Farooq, Brigadier Govardhan, and all the technical staff of the FIP, I am very thankful.
Thank you very much.
Thank you.
I was the examiner of Dr. Amir, a PhD.
Thank you. Our next, the next paper is frequency of BK viruria in post-renal transplant recipients by quantitative PCR polymerase chain reaction. So Dr. Razaullah Asif from Armed Forces Institute of Pathology will present.
Bismillahirrahmanirrahim. I am Dr. Razaullah Asif, Registrar of Virology from Armed Forces Institute of Pathology, Rawalpindi. I have no conflict of interest regarding this research article, and I shall be presenting this article with titled Evaluation of New Onset BK viruria in Post-Renal Transplant Recipients by Quantitative PCR. The brief introduction starts with BK virus belongs to Polyoma viridae family. It's a small, non-enveloped, double-stranded DNA virus, first isolated in 1971 from the urine of a renal transplant recipient with ureteric obstruction. Regarding seroprevalence, the seroprevalence of BK virus in general population is 80 to 90%. Primary infection is typically acquired during childhood via fecal-oral or respiratory route. After that, the virus goes into latency in renal tubular and uroepithelial cells and doesn't cause any disease for the rest of life. Deactivation of virus occurs after immunosuppression medicines are given to renal transplant patients, and it mostly causes infection in 3 stages, that is viruria, viremia, and then followed by BK virus associated nephropathy leading to renal graft loss.
American Society of Transplantation recommends screening for all renal transplant recipients for BK virus reactivation during initial 12 months post-transplant when cellular immunity is most suppressed. Reduction of immunosuppression is cornerstone of management for the BK virus therapy, but there is no specific antiviral medicines available. The objective of my presentation is to determine the frequency of BK viruria in post-renal transplant recipients and its association with age, viral load, and time of viral reactivation post-transplant. The rationale of my study is to identify the determinants of BK viruria and to prevent nephropathy and graft loss by timely diagnosing BK virus reactivation and guiding clinicians for tailoring immunosuppressive therapy. Regarding materials and methods, my study design was a cross-section study. It was conducted at Armed Forces Institute of Pathology in collaboration with Armed Forces Institute of Urology and Kidney Care Clinic, Rawalpindi, on a duration of 1.5 years after institutional review board approval. Non-probability consecutive sampling technique was used, and WHO calculator was used to calculate the sample size, which came out to be 108 from the study. All renal transplant recipients of all age groups and both genders were included in my study, whereas patients with more than 12 years, that's more than 12 months post-transplant period, patients with acute graft rejection, patients with late or missed follow-ups were excluded from my study. Urine samples were collected in sterile container, and DNA was extracted using 10 beads extractor and then amplified on CFX96 thermal cycler, and then data was analyzed on SPSS version 27, mean and ST was calculated, on mean and ST was calculated, frequency in percentages was calculated, chi-square test was applied, statistically significant p-value was less than 0.05. Coming on rapidly to the results. In my study, out of 108 patients, BK viruria was present in 18 patients, sir, which make us a frequency of 16.7%. Talking about the genders, in my study, out of 108, 94 were males and 14 were females. Out of 94 males, 16% have the infection of BK viruria, whereas among 14 females, 4 patients got this BK virus reactivation. So it makes 16% and 21% ratio. So it means that BK virus reactivation occurred equally in both genders. There is no discriminatory effect. Regarding age, 61% of the BK viruria reactivation took place in group 3. That is 41 to 60 years age group, followed by group 2, 21 to 40 years age group, in which the activation was 22%. So it alarms that the most of the viral, the surveillance of the BK viruria should be done post-transplant patient in this age group, 41 to 60 years, because they are more vulnerable to developing this BK viruria. Regarding viral load, 66% patients were having viral load less than 1 million copies. 17% were having 1 to 10 million copies, the moderate viral load, and 3 patients, which makes 17%, it was high viral load. And here it's pertinent to mention that this high viral load, American Society of Transplantation says that if a person has more than 10 million viral load, it can be used as a probable indicator of nephropathy, even, which is BK virus induced nephropathy I'm talking about. Regarding time of viral reactivation, 67% of patients developed BK viruria in third quarter, 7 to 9 months post-transplant period, followed by 22% in 4 to 6 second quarter post-transplant period. It means that vigilant surveillance is required during these 4 to 9 months. These 2 quarters are most important to get surveilled regarding BK virus reactivation, because most of the patients fall in these 2 quarters. Regarding discussion, a similar study was conducted in France, Amiens Hospital in 2018, in which the same BK viruria frequency was detected, and it came out to be 16.7%, which was same as my study. Another study was conducted in Institute of Kidney Disease, Peshawar, in which the frequency was just 10%, which is low as compared to my study. This is the comparison of these 2 studies. In the end, I will conclude by saying that BK virus occurs in both genders equally. Vigilant BK viruria monitoring is required, especially during 7 to 9 months post-transplant period, and significant association between age and high viral load. emphasized the importance of surveillance in 41 to 60 years age group. Further research and long-term follow-up studies may be conducted to gain a more comprehensive understanding of BQ variuria in these clinical aspects. So these are the references that I have used. I thank you all for patiently listening.
Thank you very much, it's so precise and to the point, and at least I could understand whatever you were saying. My specialty of biology. Thank you.
Now, next paper is pathogenesis of oral submucous fibrosis, relationship to risk factors associated with suspected oral cancer by Dr. Rubina Hani from Jinnah Medical and Dental College. This is Dr. Hasnan Ali from National University of Medical Sciences. His topic is effect of pre-analytical variables on concentration and purity of DNA extracted for JAK2 analysis in myeloproliferative neoplasms.
Shall I start, ma'am?
Yes, please.
You see, they can't load his presentation because he's trying to connect to those.
No issues. No issues.
Sorry.
No issues.
Dr. Rubina, you start the presentation.
I need to. इसको पेन नहीं कर सकते आप डॉक्टर रुबीना कैन यू स्टार्ट योर प्रेजेंटेशन कैन शी हियर मी डॉक्टर रुबीना
इनके साथ इशू थे टाइप इशू आ सकते हैं
Yeah, okay, I think she's starting her.
We should start the in-person first.
Okay, all right. So, Dr. Hasnan, can you come up? Dr. Hasnan,
Oh,
she's online. I think she's.
Hello everybody, this is Hasnan Ali, a 4th year medical lab trainee from Armed Forces Institute of Pathology under the auspices of National University of Medical Sciences. My topic is effect of pre-analytical variable on concentration and purity of DNA extraction for JAK2B617F mutation analysis in myeloproliferative neoplasms, and it is based on my BS thesis. Without further ado, let me give you a brief outline of what I will be discussing: introduction, followed by objective, rationale, and methodology, ethical approval, study protocol, data analysis, discussion, and lastly, conclusion. As you all know, myeloproliferative neoplasms involve myeloid lineage clonal proliferation in bone marrow. 2016 revision of the MPN is endorsed, which includes polycythemia vera, ET, primary myelofibrosis in non-BCR-ABL MPNs, and the JAK2V617F mutation being the predominant in these ones. The constitutive activation of the JAK-STAT signaling pathway and the subsequent uncontrolled proliferation of the blood cells results in the MPNs. Whole blood DNA-based techniques have become the gold standard for the detection of the mutation due to their sensitivity and specificity. My objective is to investigate the effect of age, gender, tobacco smoking, blood volume, storage time, temperature, and blood hematological parameters on the concentration and purity of ADTA whole blood DNA extracted using ion stain resin Chalix 100 for JAK2V617F analysis in MPNs. The rationale of my study is to maximize the DNA yield of Chalix 100 DNA extraction protocol and to enhance the accuracy and reliability of detecting the JAK2 mutation from the extracted DNA and ultimately benefiting MPN patients. The study design was cross-sectional study, setting was FIP in the Department of Molecular Pathology. Duration was 6 months after the approval of IRB. Sampling technique was non-probability consecutive sampling. The sample size using the WHO calculator, WHO formula, came to be 196. The formula, the anticipated population proportion used was 15%, and there were 196. Patient selection, inclusion criteria. My inclusion criteria was all ages and both genders, patients undergoing the molecular analysis for the mutation, and the exclusion criteria was the MPNs under already treatment. approval was sought from FAP Institutional Review Board. Prior written informed consent was taken. The patient confidentiality was ensured. No conflict of interest to disclose. My study protocol was to perform a complete blood picture using Sysmex XN3000, followed by DNA extraction using Bioreact's Chelix 100 chelating resin, the DNA quantification using AirTech microplate spectrophotometer. Chelix protocol in simply cells were washed with distilled water to lyse them, followed by the addition of Chelix resin, centrifugation, and vortexing, and then heating in the incubator for 15 minutes at 95 degrees centigrade. Lastly, the supernatant was collected and the DNA was retained. Species version 27 was used. Inferential statistics. I will just skip to the inferential statistics, being relevant to my topic. Normality test was applied. Data was found to be non-parametric. Kruskal-Wallis H test was used. Mann-Whitney U test experiments rank correlation with the p-value less than 0.05 was considered significant, and lastly regression analysis was performed. Here is the first Kruskal-Wallis H test. In this, I compared different blood storage times. As you can see, 2 to 6 hours, 24 to 36 hours, and so on. These 4 categories of time and their effect on the DNA concentration and the DNA purity. As you can see here, the mean rank in which the DNA purity, the significant was 0.048. You can say that that's a significant result on the DNA purity, the effect of which is discussed in the next slide, where pairwise comparison the time for the DNA purity was performed. One Ferroni correction for the multiple tests in these two first groups yielded a non-significant result, although initially they were significant. That just explains the very minor level of significance 0.048 that I just mentioned earlier. Moving on, the next was the Mann-Whitney U test. I checked the JAK2 status and the effect of it and on the DNA concentration and purity. The results were insignificant, as you can see just at the top bottom side. Similarly, in the gender, male and female, it was not significant. Moving on to the tobacco smoking, similarly it was not significant. In the blood specimen, bone marrow aspiration and the peripheral blood both were taken, and they were also found to be insignificant. And then we have the experiments rank order correlation. Here you can see quickly the correlation is significant at 0.05 level, which will be explained in the next slide. Here in this case, WBC was found to be positively correlated with DNA concentration and DNA purity. Here is the scatter plot of which you can see here the DNA purity. Now we have here the further variables. Here you can see neutrophil lymphocytes both correlated significantly and positively with the DNA concentration and purity, while monocytes, eosinophils, basophils, and lastly DNA concentration, which was negatively correlated. Here's a throwback to these scatter plots. As you can see here, the steep lines, and this is the last one. Here you can see the inverse relationship designated by the opposite line. It's going downward hill. Next is lastly, I have regression analysis. Here you can see the R-square value, which is 0.374, which roughly makes 37% of the variance. And the ANOVA table shows that it is significant. In other words, the predictor variables, which including DNA purity, immature granulocyte, eosinophils, lymphocytes, monocytes, neutrophils, and basophils, they all predicted significantly towards their dependent variable, which happens to be DNA concentration. Here you can see the individual significance levels: neutrophil, lymphocytes, basophils, Ig, and DNA purity were significantly predicted to impact the DNA concentration. Now we have DNA purity. DNA purity, you can say, you can also see here the R-square value, which is 38% variance, and ANOVA table also shows that it is significant. Similarly, here you can see the significant levels of different blood hematological parameters. So, what other studies you discussed on this topic pre-analytical variable is a topic which have been discussed widely throughout different countries, and they have established very nice protocol about it. But the impact comes here that they all use Kaizen Gentra kits, okay? But in my case, the whole process was performed through DNA inspection, Charix value, and it has the advantage of being very cheap. It's a single reagent, and it requires minimal laboratory instruments. So thereby, it can be used, and it's currently being used in FIP, and it is very
Please,
helpful.
you are running out of the time. Rather, you've taken more time. Please
Sir.
wind it up.
Sir. And lastly, the conclusions. High WBC counts, especially high neutrophil counts, give high DNA yield, very high DNA concentration comes with low DNA purity, and abnormal cell counts can impact Chalice 100 exactly DNA yield, so it is necessary to customize and optimize the protocol. These are the kind acknowledgements. We rise by raising others, and I thank you all for your patient listening. Thank you so much.
Which I could not attend. Actually, they are working on the suspected cases when we go and see that the one enzyme which is the cysteine, spermidine, and acetyl transferase 1, which involves in the homeostasis of the polycystic aliphatic amines. Spearmine and spermidine attaches. It's a rate-limiting step for their polyamide catabolism, and this polyamide helps in inflammation process, lipid metabolism, cell growth, differentiation of maintaining membrane potential, and regulating intracellular pH. Polyamide actually increases by cells in the cancer state. So we are looking, if we catch the polyamide at the first stage with the qPCR, the set one activity, and the polyamide with the analyzer, we can easily start doing the work at the from the first step. Because instead of going at the last stage, at the third or the fourth stage, the treatment goes very late and the patient cannot survive. So we started working on it, and we took the blood sample of the patient, and we know that it is the oral cancer. These are those people who have been eating pan, gutka, betel nuts, tobacco chewing, and all these things, where we are noted that B12 and the folic acid, the inflammation they measured. Our main aim is to measure the increased amount of spermidine, and acetyl transferase 1 in the blood.
Dr. Rovina, excuse me. Sorry to interrupt. Please wind it up in 5 minutes, because we are really short of time because of the problem.
I'm giving you only the results. My main objective, that we were looking at, this work has been done in Canada in the urine sample, but we are working in the blood sample. So these were the cases, and we concluded this. We had the result that we took the biopsy of these patients having these ulcers in their mouth. These are the 11 things that they have been taking with a limited mouth opening for years. They started working. Inshallah, in my next PAP conference, I will present with the biopsy reports that our work has been working very good.
Thank you very much. Very well done. Thank you.
Thank you. So now we have Dr. Maria Zahid from Dow University of Health Sciences. Her topic is investigating the current HIV epidemic in Pakistan and its comparison with HIV epidemic in Africa using molecular and bioinformatics tools.
Assalamu alaikum everyone. Now due to short of time, I think I only have 3 or 5 minutes. So I will skip my introduction of the basic from the HIV. So we'll look at the global epidemic of HIV. From 1956, the studies indicated that the most recent indicator was HIV-1 subtype A. And from 1956 to 1980s, the HIV epidemic was in a stable and phase and low and stable phase, whereas from 1980s to 1987, a rapid epidemic of HIV was seen. From 2000 and 2004, following by a stationary phase, a stabilization of epidemic. But after 2004, the pandemic began to plateau once again. If you look into the prevalence of HIV, HIV has become world's deadliest virus, claiming more than 40 million deaths over the past 3 decades. United Nations reports showed that 39.5 million people are living with AIDS across the globe, whereas 2 million people became infected with the virus. 1.2 million people have died with HIV-related illness at the end of 2021. As we are comparing our data with the sub-Saharan African model, so sub-Sahara has the most serious HIV epidemic and AIDS epidemic in the world. Nearly 60% of all new cases in 2021 came from sub-Saharan Africa. According to UNAIDS estimate that the prevalence of HIV was 3.2%, with 25.6 million people living with HIV at the end of 2021 in sub-Saharan Africa. If we see that in 1985, the prevalence in many of the countries of sub-Saharan Africa was less than 1%. But from 1990 to 2007, many of the countries in sub-Saharan Africa have more prevalent from 20% to 28%. Looking to the Pakistani perspective in HIV in Pakistan, 0.21 million people are estimated to be living in Pakistan. 53,000 are only registered with National AIDS Control Program, whereas more than 32,000 are on the treatment with antiretroviral therapy. In Pakistan, HIV-1 subtype A has been most prevalent. However, HIV epidemic is still considered to be in its early stage. During the last 3 decades, HIV epidemic is mounting. High-risk group is engaged in high-risk practices. So the objective of my study is to determine molecular characterization and phylogenetic analysis of HIV in Pakistan and to compare the local strain with global sequences, particularly with Africa, to understand the sequence similarity and possible connection of both epidemics. So for this, the sample was collected, CD4 count was done, nucleic acid extraction followed by the real-time PCR for quantification, amplification of gene, electrophoresis, nucleotide sequencing, phylogenetic analysis, proteosomal degradation, and CTL epitope analysis was done. So if you look into the demographic profile, majority were male and 16 to 30 years was the most age found to be positive, and majority were married with the risk of exposure of using injections for treatment or for drugs. I summarized my results. For phylogenetic analysis, if you look into the pie chart, subtype C was most prevalent in my study cohort, followed by subtype G, A, circulating recombinant form 0 to AG. If you look into the geographical linkages of HIV of our study cohort and the study and the sequences from different part of the world, 17.9% of the sequences were similar to the Pakistani sequences, which were previously reported, whereas other subtypes were also positive and similar with the other country sequences like United Kingdom, Zambia, China. Few were positive with the Canada, Uganda, and Rwanda. For the proteosomal degradation sites, HIV gap sequences of this study were compared with the whole genome of HBX2 sequence. Comparative analysis showed that the sequences from this study have 83.8 proteosomal degradation sites as compared to 85 in the reference sequence. This loss of sites were due to the different mutation present on upstream and downstream of the sequences. If we look into these CD8 T cell epitopes, we have seen that after comparing it with the HBX2 genome, subtype A1 has the most unique epitopes similar to the HBX2, but there were some were also common epitopes that were present in both HBX2 and the myself study cohort. Similar with the subtype B, C, G, and subtype 02AG. With this, a study showed that male age group 16 to 30 years were more affected by HIV and have the history of exposure of infection during treatment or while taking drugs. There are several subtypes that are prevalent in Karachi, especially subtype C, which was previously observed in our study cohort. It was also observed that the period of 2004 to 2007, subtype C was accounts for 48% of the global infection. The geographic origin of subtype C circulating in Karachi showed that the virus has been locally transmitted within the population. Few of these sequences showed that the origin of the sequence circulating subtypes is geographically linked with the sub-Saharan African countries, Uganda, Rwanda, and Zambia. Overall, our study sites were similar except for 85 epitopic sites. Among these 85 positions, we also observed that few mutation on the same site will have few have mutation on their adjacent upstream or downstream sites. CTL epitope variability showed that subtype A1 has a large number of epitope variability sites that were not in HPX2, the reference sequence. This might be due to loss or gain of HLA restriction pattern. In Africa, the prevalence of the virus changed with time as transmission of HIV increased from 2.4 in 1990 to 4.8 in 2000. Frequency doubled the frequency doubled once the virus started evolving and circulating among the general population. When the virus is evolving, changes occur in the virus and it becomes strong and escape from host immune response. It also develops resistance to the administered drugs, and physician and doctor cannot treat. Sadly, the case that has been reported thus far just a tip of iceberg. We can face even more worse scenario in upcoming years due to intercirculating subtype and spread of infection in young males, and was observed as it was observed in Africa in mid-1990s, where the mostly affected with the virus consist of males with age 15 to 49. Therefore, it's crucial that we need to take precautions, inform the public about infection, educate professionals, and they can have better communication for the risk to the patients. Thank you.
I think we don't have that time that we may make the discussion. I'm thankful to Dr. Natasha for organizing this excellent session. And they are very good papers. I must appreciate Dr. Maria in the end, because I was the first consultant virologist to National AIDS Control Program of Pakistan. I was the focal person of Pakistan for UN in AIDS, a regional member of the regional task force, and ultimately I was a member of the global task force of UN. Having worked in Somalia, Kenya, Uganda, and then in later on in Sierra Leone and Liberia, and then connecting all these things together, it was again a very much refreshing for me to go back to my whole of my life. I have seen HIV evolving, appearing, and going to this extent. And what I said 40 years ago, she has again repeated that it is a big threat, but I must remind you there are more viral threats like COVID and many to come. Thank you very much.
Thank you. Sorry, Professor Vahid, before you go, we do have a token of thanks. I was waiting, Dr. Asrad, would you be able to just come up and present this to Professor Vahid? Professor Vahid, it's just a token of thanks for chairing the session. Thank you, Dr. Asrad. Thank you very much. Thank you. Thank you.
You hear me, sir? Yes.
And Dr. Hajra, I apologize for the spelling mistake on your certificate. I'm really sorry. We tried to get them to correct it. Dr. Asrad, you, Dr. Hajra. Thank you for moderating so well. Thank you for everybody who was online, our speakers who were presenting online. I know it was difficult, but I think you guys managed really well. Thank you to all of you. We have a 15-minute tea break. I'm sorry, it was supposed to be half an hour, but we're kind of running a little bit behind time. So we can restart this session at 11:15.